Greetings, everyone. Today, I would like to share with you my evidence-based practice guidelines for managing COPD. I would like to begin by sharing a case scenario with you of a typical COPD patient presenting to the clinic. Mr. CO, a 65-year-old Caucasian male, presents to the clinic with worsening shortness of breath on exertion. He smokes 1 pack of cigarettes daily and has a 40-pack year smoking history. He uses 2 liters of oxygen daily and has recently required 4 liters of oxygen to keep his sats greater than 90% on his home pulse ox monitor. He always complains of feeling breathless, even at rest, and also complains of chest tightness. He uses an albuterol inhaler 3 to 4 times a day, but still feels short of breath. He denies fever, chills, nausea, vomiting, diarrhea, and muscle aches. On this slide, I would like to share with you the basic pathophysiology of COPD. COPD is a chronic inflammatory lung disease that restricts airflow in the lungs, and it mainly consists of 2 disease processes, emphysema and bronchitis. The normal physiology of respiration in healthy lungs involves oxygen entering into the lungs, and an exchange of gas is made at the capillary bed inside of the alveoli. When this occurs, gas exchange at the capillary bed allows CO2 to be breathed out of the lungs through expiration. In COPD patients, this normal physiology is not occurring due to destruction of the alveolar wall and also inflammation of the bronchioles. As bronchioles in the lungs continue to thicken, mucus production is increased. In addition to increased mucus production and narrowing of the bronchial tubes, alveolar walls are destroyed and the alveoli are not properly able to make gas exchange between oxygen and carbon dioxide, causing an increased amount of carbon dioxide to remain in the lungs. As this sequence of events continue to occur, the alveoli weaken, leading to improper gas exchange, air trapping, buildup of CO2, and decreased oxygen to the lungs and the rest of the body. Ultimately, it results in hypoxemia and hypercapnia in the patient. On this slide, I have provided you with a visual representation of a healthy lung versus a COPD lung. You'll notice that there is increased mucus production in the bronchioles of the COPD lung, and you also have the alveoli sac that are widened and destroyed. In this slide, I have listed for you risk factors of COPD. The main risk factor for COPD is smoking. Other risk factors include exposure to air pollutants, dust, chemical fumes, a positive family history of COPD, chronic lung diseases or infections such as pneumonia or bronchiectasis, a history of asthma, and also a genetic disorder called alpha-1 antitrypsin deficiency. In alpha-1 antitrypsin deficiency, the alveolar walls are destroyed leading to emphysema. In diagnosing COPD, it is essential to gather pertinent information from the patient, such as subjective findings, including feelings of breathlessness, shortness of breath on exertion, a positive history of smoking, chest tightness, and wheezing. The gold standard for diagnosing COPD is spirometry and pulmonary function testing. A patient that has a spirometry test of FEV1, FVC less than 70% post bronchodilation is the gold standard for diagnosing COPD. Other helpful essentials to diagnosing COPD is an arterial blood gas. Usually the patient will present with respiratory acidosis or an increased CO2 level. And an X-ray can also be used in aiding the diagnosis of COPD. A typical chest X-ray of a COPD patient may show hyperinflation due to air trapping, and you may see widening rib spaces. On this slide, I have also provided you a table that helps to explain the classification of the severity in COPD, and it ranges from mild to very severe. COPD patients that have a gold 4 level or very severe COPD may require hospitalizations. I have also provided you with a representation of how a spirometry flow. In this slide, I have provided you with more information pertaining to Mr. CO. So you have Mr. CO, 65-year-old Caucasian male, who presents to the clinic with increasing shortness of breath. He is pursed lip breathing and complains of worsening shortness of breath on exertion. He has the positive smoking pack year history of 40 years. He also has a history of chronic bronchitis and wears 2 liters of oxygen daily. He began to notice that his shortness of breath worsened over the last 2 weeks. He noticed that he is not able to walk more than 15 feet down his driveway without needing to stop and rest. When Mr. CO is short of breath, he often uses his albuterol inhaler, but he noticed during this time he did not have any relief when using his albuterol inhaler. Some things that Mr. CO did to try to make his symptoms better included increasing his oxygen from 2 liters to 4 liters. And he also increased the frequency of his albuterol inhaler use. In spite of making these changes, Mr. CO still feels very short of breath. He describes his feelings of breathlessness as breathing through a straw. Mr. CO increased his oxygen from 2 liters to 4 liters and noticed on his home pulse ox monitor that his SpO2 level increased from 88% to 93%. But in spite of this, he still feels very short of breath. He also states that he is having yellow sputum production, and a chronic cough. Mr. CO does not have any allergies. His past medical history includes hypertension, chronic bronchitis, BPH, and urinary retention. He does not have any surgical history. His medications include ProAir 90 micrograms, amlodipine 10 milligrams daily, and Flomax or Tamucilin 0.4 milligrams daily to assist him with his urinary retention. Mr. CO did express that he received his flu vaccine last year in October, but has not received the pneumonia vaccine. In Mr. CO's family history, his mother is deceased and she has a history of diabetes. His father is also deceased with a history of CVA. His brother is living. He also has a history of diabetes. And he has 2 adult children, one daughter that's living, her history is unremarkable, and a son that's living with a history of asthma. There is no family history of cancer, seizures, alcohol abuse, or illicit drug use. Mr. CO's social history includes he is a widow and he lives alone in a single-story home in a rural community. He is retired military and his health insurance is TRICARE for Life and Medicare Part B. His diet mainly consists of rice, vegetables, fish, chicken, some fried foods, and fruit. He occasionally drinks sodas, but primarily drinks water. His exercise regimen of walking has been reduced due to his reduced lung reserve and feelings of shortness of breath. In conducting the review of systems on Mr. CO, he is ill appearing, breathless, and anxious. He does not have any history of head trauma or surgery, no history of tinnitus or visual problems such as glaucoma or blindness. He does not have a history of epistaxis or nosebleeds, no nasal surgery, no oral or throat surgery. He denies rashes and itching. He does not have a history of an MI or cardiac surgery. He denies chest pain, but does complain of chest tightness, and he has a positive history of hypertension. In reviewing his respiratory status, he has a positive history of chronic bronchitis, shortness of breath, yellow sputum production, chest tightness, oxygen use, and family history of asthma. He also has a positive use of ProAir inhaler. Pertinent objective data to diagnose COPD in Mr. CO. Pertinent physical exam findings for Mr. CO include his barrel chest, his diminished breath sounds, shortness of breath on exertion. He has an increased respiratory rate and an increased heart rate and complaints of chest tightness. He also has bilateral lower extremity edematous edema that is non-pitting. He is also noted to have a prolonged expiratory phase in his respiratory cycle. In evaluating Mr. CO's laboratory and diagnostic results, it is noted that Mr. CO has respiratory acidosis with mild hypoxemia. On his chest x-ray, it shows hyperinflation and flattened diaphragm with perihilar congestion. In reviewing his CBC lab results, it shows that he does not have an infectious process going on due to his white blood cell count being within normal range. However, it does show that he has an increased amount of red blood cells and an elevated hemoglobin, which may indicate polycythemia. In assessing Mr. CO's labs and diagnostic tests, the following differential diagnoses were determined. 1. COPD to rule in. 2. Pneumonia to rule out. And 3. CHF to rule in. Also on this slide, you will notice that I have displayed other common tests or procedures that are common for COPD patients, including pulmonary function testing, a 6-minute walk test to determine their oxygenation level, and requirements for home O2, an arterial blood gas, a CBC, chest x-ray, and ultimately an office visit. As the first differential diagnosis of COPD, the following information supports the differential diagnosis. A spirometry test of less than 70% post-bronchodilation, Mr. CO's complaints of chest tightness, and his shortness of breath on exertion. For the second differential diagnosis, pneumonia, it can be ruled out due to Mr. CO not presenting with a fever. He did not show any infiltrates on his chest x-ray, and he does not have leukocytosis. However, he does have yellow sputum production, which is also common in COPD patients, along with chronic cough. And lastly, the third differential diagnosis of CHF. Supporting data includes dyspnea experienced by Mr. CO, his physical exam findings of bilateral lower extremity edema. Both COPD and CHF can often have similar findings, but it is not usual to find chest tightness in CHF patients. So my final diagnosis for Mr. CO is COPD due to his spirometry results and presenting symptoms of dyspnea on exertion. On this slide, I'll discuss the management plan for Mr. CO, which will focus on interventions that will help slow the disease process and provide the patient with the best quality of life. The framework that was utilized is the self-care of chronic illness framework. The self-care of chronic illness framework was utilized because it focuses on the importance of the patient being an active participant in their care, which is ultimately what you want most COPD patients to do. By having COPD patients such as Mr. CO be active participants in their care, this will increase compliance and ultimately decrease hospitalizations and slow the progress of their disease. Some pharmacological interventions that Mr. CO will require include a short-acting beta agonist or a SABA, such as albuterol or ProAir HFA inhaler. Also, a long-acting muscarinic agonist or ipratropium bromide or tiotropium bromide. A long-acting beta agonist or LABA, such as salmeterol or formoterol. Inhaled corticosteroids, such as fluticasone, and sometimes the use of oral steroids or systemic steroids, such as prednisone, are needed, along with an antibiotic if there is an exacerbation of COPD involving pneumonia or other bacterial infections. In this slide, I included this table. I thought it was pretty interesting. It gives a great representation of a stepwise fashion of how to approach pharmacological treatment for COPD patients based on their FEV1%. Some non-pharmacological interventions that Mr. CO could benefit from include avoidance of triggers such as air pollutants or chemical fumes, dust. Also, stop smoking, which is the biggest issues that COPD patients have. And also being actively involved in pulmonary rehab. Pulmonary rehab is a proven intervention for COPD patients, and it allows them to learn breathing techniques and exercises that will help them preserve their lung reserve and complete everyday tasks. Education is another major component of the management plan for COPD patients, including the uses of medications and side effects, knowledge of what triggers they should avoid, including cessation of smoking, and also preventive tasks that the COPD patient needs, such as obtaining an annual flu vaccine and also the pneumonia vaccine. Prior to educating COPD patients about their condition, it is important to assess their readiness to learn and also their ability to learn. Some common education pertaining to medications for COPD patients include rinsing their mouth after the use of an inhaled corticosteroid to reduce the development of thrush, and also utilizing a spacer device to help improve medication depth into the lungs. Another major component of the management program or guideline for COPD patients include referral resources, and follow-up. On this slide, I have listed multiple resources that are available to COPD patients. It is important for healthcare providers to have these resources readily available to COPD patients to improve and increase compliance. For follow-up, Mr. CEO will require a multidisciplinary approach, which may include a home health checkup by a nurse or a respiratory therapist. He needs to keep his routine monthly office visits, and if his symptoms worsen, he needs to immediately call 911. A routine office visit for Mr. CO would cost approximately $103. Since Mr. CO has both TRICARE for Life and Medicare Part B, he would only be responsible for $15 of his visit. For office visits, nurse practitioners can receive up to 85% reimbursement. So for the office visit for Mr. CO, the approximate reimbursement that the nurse practitioner can receive is $87. The nurse practitioner will also need to refer Mr. CO to pulmonologists for a pulmonary functions test and also a chest x-ray. She may also need to implement home health services for Mr. CO to help him with his activities of daily living. According to Medicare.gov, this will not be an out-of-pocket service or cost for Mr. CO. So lastly, in managing a patient with COPD, it is important to encourage them to stop smoking. That is the most important key to successful management of COPD. Education is also a major factor for Mr. CO to ensure that he understands his disease process and medication use. By providers supplying COPD patients with community and online resources, this will help reduce hospital admissions and readmissions. The ultimate goal for Mr. CO is to regain at least 50% of his lung function and remain active so that he can self-manage his symptoms and have a purposeful and productive life. In these next slides, these are my references. I also included an appendix to show what typical COPD lungs on an x-ray looks like, and also a healthy patient versus a COPD patient's pulmonary functions test. This is the end of my presentation. I would like to thank you for your time and attention.